think that there are certain things that will change for sure. I think there are questions such as the need for risk-stratified treatments. Should we do blood tests or different types of tests up front and then choose therapy based on that? Or should we treat patients who have more standard risk with the best drugs? One could argue that those patients potentially could have the greatest upside of the newer drugs. And in fact, if we look at patients with more high-risk features, those patients barely have any improved outcome, even in the era of the most effective drugs that we have today. So maybe it's time to rethink and give those patients completely different therapies. Also, the duration of therapy is probably going to be different in the future. What's the role for extended dosing, maintenance therapy? What's the role for measuring responses using minimal residual disease? I personally think that's a major question we need to work on, because the new drugs can take many patients into complete response using standard criteria, while minimal residual disease is going to be the new endpoint, in my opinion, and we need to come up with a consensus how we define that. And we can use that for drug development, for approval of drugs, and for patients, of course, this is very, very important, because now we are really talking about trying to find a cure for the disease.